Saba Samreen, a consultant rheumatologist practicing in 40 Foundation, Rawalpindi. Dr. Samreen brings a wealth of clinical experience and expertise in musculoskeletal assessment, with a strong commitment to advancing rheumatology practice and training in the region.
Her talk, titled Knee Anatomy, will cover key anatomical landmarks essential for accurate ultrasound assessment and interpretation of knee joint. Please join me in warmly welcoming Dr. Saba Samreen to the stage.
Hello, Assalamu alaikum, everyone. It's an honor to be here, and being a part of 28 PSR is definitely delightful. Happy to see our APLAR, AYR group members and ambassadors, and as well as the convener here. So before I begin my scan, there was a message given to you by Qatar Rheumatology Association. They are running a musculoskeletal ultrasound course which would have basic, intermediate and advanced courses within it from 4th to 7th of December. The early bird concession is still on, and this waiver can be utilized until the 30th of this month. And it is ULAR endorsed course happening over there. So those who want to join, they can actually do so. Let me not keep you waiting. We'd be going through the knee scan. You all know the utilization. Let me just tell you that knee is one of those scans which, even if you are not a rheumatologist and orthopedic, probably more useful for them than us probably. So it's one of those joints which would need scanning really oftenly in your clinics. You might need to do it for diagnostic purposes, for therapeutic purposes, and it is one joint which has a constellation of abnormalities which can be picked up. You might be able to pick up effusions, the mild ones which could be hidden within the recesses. You would be able to pick up arthritis. You can look at the quality of the cartilage and see if somebody is having early osteoarthritis. You can actually look at the loose bodies. You can actually look at the nerves. For those people who have advanced osteoarthritis and don't really want to go for the knee replacement, they can actually have radiofrequency ablation, and if you want to locate their nerves, even musculoskeletal ultrasound would be utilized to locate them. Similarly, crystal arthropathies and the really world famous double contour sign would be something that we'd be coming across shortly. So you just don't need anybody. You need your patient, yourself, and then a probe, which should be a linear probe. So most of the scans you have done until now, you only used one probe. Only in the hip joint, you'll be going to the other probe. So make sure you have already taken a really good history. You have inspected your patient well, especially gout patients. They are already very tender. Make sure you show your gentle, tender touch to them. You don't touch them very vigorously. Make sure you have palpated and already have a clue of where the tender points would be. And obviously range of motion should be checked before going and proceeding with the procedure, so that you know what sort of mobility or dynamic maneuvering would be possible, so that you don't really jump to, you don't have any surprises, oh, my patient can't be prone. Or so while we talk about anatomy, just a recap of the basic things we can actually come across into a knee joint. We'll be looking at the bones. So make sure you have your anatomy right. We definitely know it's femur, then tibia below. Fibula makes up a really nice small joint with the tibia, which is the tibiofibular joint. So superior part of the superior tibiofibular joint should be recognized where visible. Then patellofemoral engagement should also be visible to you, and we'd come across it when we do the anterior knee scanning. Then the extensor tendons would be quadriceps as well as the patellar tendon lower down. Then posteriorly we'd be coming across biceps femoris, lateral hydrogastrocnemius popliteus, and semimembranosus and semitendinosus towards the medial side. Now, apart from the muscles and the bones, we'd be coming across recesses, and the most notable recesses are the suprapatellar recess. We'd be coming across a few pictures. Can you see my pointer? Yes. So this is the area where the suprapatellar recess would be found, and this is the first one where the knee fusion would extend to. Then parapatellar recesses, I call them the surprise boxes, because if you don't find any effusion in the suprapatellar fossa, the second area should be the parapatellar recesses. Do look for effusion over there. You often find something if your patient is in pain. Then medial and lateral posterior femoral recesses as well. a number of bursae around the knees, and yes, when we talk about basic knee scanning, a lot of them are not really important, but yes, some major recesses, some major bursae should be recognized. The most important being the suprapatellar bursae, then the prepatellar bursa. Similarly, when you go into the infrapatellar tendon, there is superficial and deep infrapatellar tendon bursae. They should be looked at and identified. Normal bursa are not visible. They are only visible when they are distended, inflamed, and filled with fluid. And similarly, if we talk about prepatellar bursa, you might not be able to recognize it at all. So make sure when you do anterior scanning and you're suspecting a prepatellar bursa, your grip, your touch, your hold should be really gentle. You do not apply so much pressure as to displace the fluid or to completely obliterate it, right? Now, there are a number of standard scans. I'd not be enumerating all of them for you here because we'd be going across them a bit by bit. In the anterior knee, just imagine that in knee scan, you have to go longitudinally from top to bottom. So suprapatellar longitudinal scan, transverse scan in the neutral position, then inflection, and similarly infrapatellar scan, both longitudinally and transversely would be done anteriorly. This is just review of the structures you would be seeing in the anterior knee compartment. Make sure you are able to identify the quadricep tendon. While doing the anterior knee, make sure your patient is lying supine, the knee is in extension or 20 to 30 degree of flexion. And I'll tell you why do I mention both the positions where there could be variability in the findings based on it. Ideally should be in flexion 20 to 30 degrees. An indicator, so far you have learned it always should be towards the head of the patient, and you should have an idea of what the proximal part of the image would look like. So in anterior longitudinal scan, you see a structure like this. This part is definitely the bone that you see here, which is patella. So when you put your probe longitudinally onto the upper part of the knee, make sure your probe is bridging the femur as well as the upper part of the patella. Once it bridges, you would be able to see part of patella as well as the quadricep tendon. So let me label that for you. You'd be able to see patella, quadricep tendon. Then just beneath the tendon has then again the same, the linear array of the fibers attached very neatly, and you can appreciate the texture that it has. Now, just below it, you see two important structures. One is the suprapatellar fat pad, and lower down is the prefemoral fat pad. Now, let me take you back to the image. This is what a fat pad would look like. It does not have any definitive structure. And when a knee is distended with effusion, the fluid tends to displace these fat pads, and the recess, the suprapatellar recess that we talked about, is present. If my pointer would come anywhere, it's not even visible onto the structure. Okay, let me make use of the cursor. This is the part where the recess is. So if somebody has got a massive knee fusion, this area would be distended, and this is where you'd see a lot of effusion in people who have got knee synovitis. Now, why do I mention both positions? See, in suprapatellar view, when you are extending, the quadricep tendon seems to be missing at this part. And as soon as you flex the knee, you tighten the quadricep tendon. And once you tighten it, you make sure that all anisotropy, which was giving you a false impression of a tendon injury, has abolished. So make sure you have the suprapatellar view in the flexion of the knee. Always make use of your hand well. Make sure your scanning is dynamic and you appreciate the quadricep tendon. Also, another important thing is when you see the quadricep tendon, try to map it all the way to the patella, and as you appreciate towards the ending onto the patella, it is fanning out. So this is not a tendinitis that it's enlarging, it's a normal way it attaches to the patella. So normal anatomy should always be appreciated. Now the same place, we stay on top of a tendon. Now we are going to go extremely at the 90 degrees at the same point. So we are now going to do the suprapatellar transverse scan. Now once you do transverse scan, you see something like this. Okay, this area contains the quadricep tendon, and quadricep tendon is basically made up of 4 tendons coming up and a myotendinous junction before they converge onto a tendon, and The upper part, the extremely thin slip part, it has the rectus femoris. Both coming medially and laterally would be the vastus medialis and lateralis, and the lower part of the tendon is composed of the vastus intermedius. So they all connect together and make up the tendon. So the area of interest is this part. Now let me elaborate it further. So this is the quad tendon, and again rest of the structures would come below, iliotibial band as well as the vastus medialis, some end of biceps femoris if you're, depends on where you have the probe placed. Now once you are done with the suprapatellar longitudinal as well as the transverse scan, do one thing more, make sure your patient has a complete flexion of the knee. This would make your articular cartilage visible. So this is the articular cartilage. A lot of important key concepts here. Cartilage interface sign is important because the integrity of the cartilage is dependent upon the insulation angle, and similarly in people who have got monosodium urate crystal deposition, you might see a hyperechoic line over the surface of the superficial layer of the articular cartilage. So that has to be looked at by changing the insulation angle. If that hyperechoic line stays, it is the double contour sign. If it abolishes, this is simply the cartilage interface. This is the quadricep tendon over it, and this asteris is actually the part which denotes the cartilage. So in people who have advanced osteoarthritis of the knee, this cartilage would be, very hazy. It would not have a very sharp margin, and it might be reduced in thickness. So a lot of researchers would be looking at the thickness of the cartilage when they are looking at osteoarthritis knee for measurement purposes. Now, as you are done with the upper part of the patella, now you're coming onto the patella. So prepatellar knee scan while you go to the infrapatellar area. In prepatellar knee scan, you're going to do the transfers as well as the longitudinal scan depending. So the transfer scan would show you the patellar tendon as you are tracing it down. Now, infrapatellar longitudinal scan can be done in extension or flexion both, depending. If you see anisotropy, make sure you have it slightly flexed to continue the same 30-degree flexion position while you are continuing down. What do you appreciate? Now the patella has finished. You have slided off from the surface top of the patella. You see the patellar tendon. It's going very nicely. It's not heterogeneous. It's homogeneous, and it's attaching onto the tibia. Now, just beneath the surface of the patellar tendon, what do you see? You see fat. Similar to the suprapatellar fat pad, this fat has no definitive structure, and this is the Hoffa's fat pad. So a lot of people who would have tenderness into the infrapatellar area, especially those who have spondyloarthropathies where you might be expecting enthesitis. So for enthesitis, my area of interest would be this part. Now, if somebody has got some bursitis, I might be able to see some fluid down here. So this whole structure becomes really relevant when you are looking at people who have spondyloarthropathies, especially the enthesitis. And make sure once you are looking for enthesitis, we have to use the color Doppler signals, and you do not apply a lot of pressure because you might be ameliorating and completely obliterating any signals coming in. So I guess we are all together up till now. For those who are awake and are done with the tea, they might be mentally present. Now, infrapatellar transverse scan, you are done with the longitudinal part of it. So now you're going to, just move your probe 90 degrees to the other side. Now we are at the same part, but now we are at the infrapatellar part. So the same area where we see the infrapatellar tendon and Hoffa's fat pad, but this is just another view. So whenever you see a pathology in musculoskeletal ultrasound, do not rely on one side of the picture. Always have the other side listened to and looked at. So all pathologies should be labeled and should be looked at in both the planes, whatever the structure. Now we come across the next part, which is medial knee. So now we are done with the interior knee, we are at the medial knee. It is best examined with the leg externally rotated, with the knee in extension or slightly flexed, and the structures of interest would obviously be your joint, as well as the meniscus over there, and somewhat down 5 centimeters below the joint line, there is a pes sensorine complex, which is of extreme importance for those people who might have tenderness at that area, and we want to look at pes sensorine bursitis, so that would be our area of interest. So when you're doing a medial longitudinal scan, you'd be coming across the structures, that is femur. So femur is this part, and shown to you as a hyperechoic line over there. Next is the medial meniscus, and then tibia and medial collateral ligament is again running on top. Now, apart from seeing some part of the meniscus, you might not be able to appreciate the full meniscus. It's only 1/3 of it that is actually truly visible in all remarks. And similarly, no matter how good of a scanner you are, you would not be able to appreciate cruciates. So there are a few limitations when you are doing knee scan. If clinically your patient's drawer signs are positive and has had a sports injury, your scan might guide you, but for completely seeing the cruciates, you still would have to jump to the MR scanning. Now coming to the pes anserine bursa. It is made up of tendons of sartorius, gracilis, and semitendinosus, and it always inserts into the anteromedial aspect of the tibial metaphysis, approximately 5 centimeter below the joint line. So once you are at the area, just make sure you move your probe slightly downwards and you leave the joint area. So previously you were at the joint line and you were seeing the joint between the femur and tibia. Now you're moving slightly below and you'd be able to appreciate the pes anserine attachment. Now the point of interest is actually how do you know you're at the right place? You'd be able to appreciate the inferior medial genicular artery. Now the lateral knee, make sure once you are doing the lateral knee from anterior to posterior, you are able to appreciate not only the joint, not only the lateral meniscus, but also 2 other structures, the lateral collateral ligament as well as the iliotibial band. So iliotibial band, as we all know, is an extension of the fascia lata, and it comes down, and once it attaches to the lower end of the tibia, it would fan out. Again, the fanning out at this part should not be counted as an injury. This is the normal attachment of the iliotibial band. And again, the linear array arrangement of the band should be appreciated. And again, if you're not able to appreciate, make sure you just wiggle and have some dynamic maneuvering of your probe to try bringing that picture into your probe's window. Apart from that, you'd be able to see lateral meniscus as well as the joint cavity. Some part of joint cavity might be visible. So some effusion which is flowing out of the joint, displacing the tendon, might actually be visible here. And similarly, those people who are elderly, have advanced osteoarthritis, you might be able to see small collections extruding from the meniscus, such as meniscal cysts. So some amount of meniscal pathology might actually be quite visible here. Iliotibial band inserts at the Gerdy's tubercle, and again the same thing, that fanning out should not be taken as an abnormality. So once you are seeing the iliotibial band, it lies over the lateral collateral ligament. We have seen the iliotibial band independently in the previous scan, and now once we see them all together, iliotibial band is the superficial part, it's the thinner part, and it attaches at the tibial head once you follow it. Then comes the lateral collateral ligament. It's superficial to the lateral meniscus, and again it attaches proximally to the femoral condyle and distally to the fibular head. Now we come to the last part of it, which is the posterior knee, and of extreme importance because of the presence of, some people are awake. So yes, that happens with the end of the session. So you have to be mentally present. If required, you can do different degrees of flexion, and obviously you have checked your patient priorly, you know what sort of range of motion your patient has. You'd be able to make the patient prone, you'd be looking at posterior knee. Before we go into the popliteal fossa, I just want you guys to revise a bit of anatomy before we go to the hands-on session. In the upper part of the knee, supromedially, we'd be seeing semimembranosus. Supralaterally, there is biceps femoris, and lower down, gastrocnemius occupies the lower half, both inframedially and laterally. So the center of the fossa, which is actually covered by the popliteal fascia, which is an extension of the fascia lata, it is occupied by artery, vein, and nerve in the same order from medial to lateral side. Now, similarly, tibial nerve, it actually is a part of the sciatic nerve. Sciatic nerve branches high above, and it gives common fibular nerve, which is passing alongside the biceps femoris tendon. So have your anatomy right. Do not forget the tendons so that you have an idea of what tendon you are able to visualize. Now posteriorly, we are going to see it in 2 scans, medial. Yes. If you're able to do medial longitudinal scan, and similarly in the medial longitudinal scan, you'd be able to see semitendinosis, tendon, semimembranosis, medial meniscus, and medial head of the gastrocnemius. So this is the posterior medial longitudinal scan. Now, posterior lateral longitudinal scan is when you move your probe longitudinally but towards the lateral side. Here you'd be able to see lateral collateral ligament, the belly of the tendon of the, the muscle part, and the tendon then goes down of the biceps femoris, and the lateral meniscus as well to some extent. Lateral meniscus is visible in the lower part of the image in the form of an asterisk. Now comes the last part where you are done with the longitudinal scanning of the posterior part, and you're going to move your probe transversely. Once you move your probe transversely, try identifying the medial head of gastrocnemius. Now, medial head of gastrocnemius overlies the popliteal artery. Popliteal artery should be visible underneath it. And once you see it, make sure you are able to identify medial head of gastrocnemius, semitendinosis. This asterisk or star is the semimembranosus tendon. And this is an area of extreme importance because the Baker cyst, once it is distended, would actually come in between this area and would be visible extending if it has fluid collection. Again, the posterior transverse scan and a complete pictorial depiction so that you guys have a pictorial memory of it. And let's proceed to the hands-on session. And this is since the last station. After this, you guys are, that would actually be the concluding session, the hands-on session. So just a quick reminder before we move on and we go through the pitfalls. You guys, if you want to participate in the Qatar musculoskeletal ultrasound course, they have given another reminder. You guys can actually have yourself booked since the early bird concession is still running. It's happening on 4th till 7th of December in Qatar. Pitfalls before I leave this place. Do not apply too much pressure. It applies to, no matter which joint you are scanning. You can have mist effusions, you can displace fluid, and if somebody's having Doppler signals, you'll actually obliterate and kill them. So don't do that. Similarly, if you're applying too little gel, you will not produce any interface, and missing an interface would mean that you're not able to visualize anything below. Similarly, do not interpret anisotropy as a tear or a cyst. That's pretty much it. Thank you. Thank you.
We now move to the next hands-on training session of our workshop. Participants are requested to proceed once again to the ultrasound stations for continuing practical demonstrations. With that, we conclude the musculoskeletal ultrasound workshop, an insightful and truly hands-on learning experience. We hope these sessions have enriched your understanding and confidence in musculoskeletal imaging and its application in everyday rheumatology practice.
We'd like to extend our heartfelt thanks to all the facilitators, speakers, and participants for their active engagement and enthusiasm throughout the workshop. I would like to now invite Dr. Ahmed Said, Convener and President of Pakistan Society for Rheumatology on stage to present to all facilitators a token of appreciation to commend their efforts. Thank you, sir. Ladies and gentlemen,
I request there is an announcement. We have formal inaugural of the conference, which is going to be at 7:45 p.m. in Grand Ballroom B. So we would like all of you to assemble there. I'm saying assemble there. The President of College of Physicians and Surgeons, Professor Khalid Masood Gondal, is the chief guest. So we would love to have you and your families, and there is a cultural evening there as well. So you would love that. So you take my words, you would love that. Okay, thank you. And the food would be awesome.